Today's lesson is about the introduction to the respiratory system, presented by Joe Newhouse, BSN RN, CEN. The lesson's purpose is for practical nurses to understand the basic normal respiratory anatomy, physiology, and diagnostic procedure to test nursing assessment, nursing intervention, in preparation for learning the respiratory disease. Say the material presented and your work shall be rewarded, according to 2 Corinthians 15:7. Have you ever been in a store or seen a person walking around with a nasal cannula, something in their nose, and pulling an oxygen device? What has caused them to have the need for so much oxygen? Have you ever been short of breath, running hard, breathing hard? All those breathing issues are directly impacted by the respiratory system. During this lecture, I will introduce terminology, pathophysiology, and diagnosis procedures in nursing care. For learning objectives, our students will be able to define key terminology related to the respiratory system. Students will understand the normal anatomy and physiology of the respiratory system. Students will be able to describe the nursing assessment for patients with respiratory disorders. Students will be able to describe the nursing intervention of the patient teaching for diagnostic tests for the respiratory disorders. And students will interpret arterial gases. Learning objective. First, we want to talk about definitions. So the first thing is we want to really work on the cognitive. So during this, we're going to break up into groups and we're going to break words apart. So we're going to start, for instance, dyspnea. Dyspnea has two parts. Dys is difficulty and apnea is the breathing, so difficult breathing. So we're going to do that. We're going to break up in groups right now, and then we're going to come back. All right, I'm going to go through all the rest of the... All right, now I'm going to go through these key terms. As we've already discussed them, you got them in groups, and we'll discuss them one at a time. So advantageous is abnormal sounds superimposed on breath sounds. Atelectasis is collapse of lung tissue, preventing the respiratory exchange of carbon dioxide and oxygen. A bronchoscope is a visual examination of either the larynx, the trachea, or bronchial, using a standard rigid tubular flexible fiber optic bronchoscope. Crackles, they're short, discrete, interrupted crackling or bubbling sounds. This is when we're oscillating the chest, heard upon inspiration. Cyanosis, so a slightly bluish gray, dark purple discoloration of skin resulting from the presence of abnormally reduced amounts of oxygen, hemoglobin in the blood. We got dyspnea, what we talked about before. So it is shortness of breath, but usually we're difficulty breathing. You're having some type of difficulty. So it may be caused by a disturbance in the lungs, certain heart conditions, hemoglobin deficiency. You just ran hard, so you're difficult breathing. You're having a hard time getting your breath. Embolism. So this is an obstruction of blood vessels by a foreign substance, blood, clot, fat, or air, and this is within the lungs. Edema is accumulation of pus in the body cavity, especially in the pleural space, as a result of an infection. Epistaxis. Everyone, this is a nosebleed. Hemorrhaging of the nose. Exacerbation is increase in the severity of the disease or disorder, marked by increase in signs and symptoms. So then we have extrinsic, anything caused from outside the body. And then hypercapnia is greater normal amounts of carbon dioxide in the blood. And hypoventilation, an abnormal condition of respiratory system that occurs when the volume of air inhaled is not adequate for metabolic needs of the body. So next word is hypoxia, an inadequate reduced tension of cellular oxygen. Intrinsic, remember we already talked about extrinsic, now intrinsic is called the internal factors of the body. Orthopnea is an abnormal condition in which a person sits or stands in order to breathe comfortably or deeply. Pleural friction rub, this is actually rubbing of the pleural against your ribs. So it's a low-pitched grating or crickling lung sounds that occur when inflated pleural surfaces rub together during respirations. Pneumothorax is a collection of air or gas in the pleural cavity which causes the lungs to collapse. Wheezing is a musical high-pitched squeak or whistle-like sound caused by rapid movement of air through narrowed bronchioles. Tachypnea, this is when you're breathing hard. You're breathing over 20 times a minute. So bronchus, thoracentesis is a surgical perforation of the chest wall and pleural space with needle of the aspiration of fluid for diagnostic and therapeutic purposes. And virulent. So this is the power of microorganism to produce disease. So next learning objective. So we're now going to break up in groups and we're going to draw. So before we go into, I want you to think, how do you think air flows through the body? So I want you to draw from the mouth to the cells and back. How do you think everything goes? And through the lecture, we'll go through it. All right, again, this is the learning objective. Students will understand the normal anatomy and physiology of the respiratory system, which is the flow of the air in the body. So anatomy and physiology, external respiration. So it's an exchange of oxygen and carbon dioxide between the lungs and the environment. And then internal respiration is exchange of oxygen and carbon dioxide at the cellular level. As you go through your drawing out, think about these things. So anatomy and physiology. So the upper respiratory, you have your nose, your perineal sinuses, your smell receptors, your nasal lacrimal ducts. So you got your throat, your pharynx, and nasopharynx, oropharynx. All of the pharynx, but it's based on where. So it's your larynx, your oral, or your nasal. So then the station tubes. You know, this is where kids get ear infections because of the angle of the tubing, the drainage, or can't drain. So larynx. Most people call it, oh, this is your voice box. It is. The true vocal cords are in the picture as well. So here's your trachea, got the cartilage rings around it. Your thyroid cartilage, little pointer there is called the Adam's apple. We have it, we do not, but that they have that piece, but not as pronounced right there. So, and they're C-ringed. They're not completely around. So anatomy and physiology, lower respiratory tract. So we got bronchial tree, left and right bronchus, bronchioles, terminal bronchial, alveolar ducts, and then the very bottom, the alveoli. So one of the main things to remember is that which side, how it deviates, because you'll hear a left-sided intubation and only one side of lungs going up because the way the tubes turn, what's easiest, the tube's going to go the easiest route. So mechanics of breathing. So thoracic cavity, lungs, is a large paired spongy cone shaped organ. Right lung has 3 lobes, the left has 2 lobes. Why do y'all think? Obviously the left has 2 lobes because there's the heart that's taking up one area where the third lobe would be. So as we go through when you were drawing, this part really helps you to understand this. So lungs, gas exchange occurs via diffusion. Oxygenated blood returns to the heart via pulmonary vein for distribution to the body. Visceral pleural is a thin, moist, serous membrane that covers the surface of each lung. This is why, like if it's rubbing, that visceral pleural keeps the rub. So you don't hear it, you don't have that pain, but if there's an issue with the pleural, you don't have that fluid, serous fluid in there, that can cause issues. So now physiology, parietal pleural. It's a thin, moist membrane, as we were talking about before, covers the thoracic cavity, and it's the pleural cavity, the airtight vacuum that contains negative pressure that keeps the lungs inflated. So there's negative pressure inside the lungs, which is more negative than the outside pressure, and then there's negative pressure in the pleural spaces that keeps the lungs pulled. And so you have negative, negative, then you have negative pull, negative all pull together. They keep the lungs open as well. So now you show respiratory regulation. Respiratory movement arranges rhythmic movements of the chest walls. Ribs and muscles allow air to be inflated and exhaled. So then we have the regulation of respiration, which is your nervous system control. What controls it? It's your medulla oblongata and pons of the brain. And so then you also have chemoreceptors in the carotid and the aorta. So it's chemo putting the CO2 level. Everyone thinks this is oxygen, it's the CO2 level. Too high CO2 level, too low. That's what's going to cause I need to breathe more. I need to get rid of the CO2. So next learning objective is students will be able to describe nursing assessment for patients with respiratory disorders. So it's typical ER in the bay at our hospital to have respiratory distress patients and needing different levels. So we have 4 of them for our left for this lecture. And so we'll kind of talk about some of what was going on with them. Why are they sitting up? Why are they leaning back? Why are they so thin? So nursing assessment. Reasons you may perform extensive respiratory assessment. So yeah, I think there's every once in a while they come in with a ankle injury in the ER. We don't do a big respiratory assessment because they're talking to me, before I was in follow chest. They meet all the things I can visually see. But when they come in and have difficulty breathing, we want to get an in-depth in what's going on. So, reason for performing extensive respiratory assessment: chronic respiratory cardiac condition, history of respiratory impaired related trauma, or recent surgery and anesthesia. So subjective data is shortness of breath, dyspnea, cough. That's what their objective is, what we can see. So expression of the chest movement, I see it go up and down, or seesawing back and forth, or one's going on, one's not. One has breath sounds, one doesn't. Hyposmia, the breath sounds. So at this point in the class, we would actually go to this website and we would listen for our audio learners, to actually hear the breath sounds. At this point, we would pause and go to that video. So you have a patient sitting up. They're inside the bed. Their hands are on their knees and they're leaning over. We call this tripoding in the bed. The most important thing, what's the first thing to do first? Well, he needs oxygen. He is air hunger. That's what's going on with him right now. So he needs so much air, and the only way he can get this is in this sitting. So we need to provide him with oxygen because we don't control his breathing respiratory rate. He's going to get so tired that he's going to stop breathing. And then we'll end up being on CPR. So we want to take steps to keep that from happening. So next learning objective is students will be able to describe the nursing intervention the patient is teaching for a diagnosed test for respiratory disease. So chest x-ray. Visualize the lungs, measure thoracic vessels, view alteration in the size, location of pulmonary structures, identifies lesion, obstructs foreign bodies and fluids, shows disorders, confirms pneumothorax, pneumonia, pleural effusions, pleural edema. We need to make sure we remove the joint. Also CTs. So scans the lungs can be viewed diagonal or cross-sectionally. It requires patient teaching increased anxiety. It's not like an MRI where it's totally enclosed, but you do kind of go through. And if they're given contrast, you need to make sure they understand it's going to be a warm feeling going through their body, and it's going to make it feel like they're going to pee their pants, but they don't actually pee their pants. It's just that warm feeling. So that needs to, and you need to check to see if they're allergic to iodine or contrast before they go to the CT. Okay, so pulmonary function tests performed to assess large and small airways, obtain information on lung volume, ventilation, pulmonary respiratory gas and exchange. So we need to make sure we understand the lung volume, the capacity, inspiration capacity, and total lung capacity. So diagnostic test, this is immunoscoping. So it's the scope of the this area, and they're looking for the biopsy too. All these tests need to have, these type of tests need to have a procedure, and you need to approve the consent from the patient. So bronchoscope, it's a tube going on so they can see everything that's going on. So we need to inform the signs before procedure, NPO until gag reflex returns, place instrument flowers position, turn to one side, monitor founds laryngeal edema, spasms, monitor sputum for signs of hemorrhage if biopsy. So we do sputum specimen, obtain for collection, explain to the patient why you need it, collection before prescribing antibiotics, collect. So we'll go through how we do it. This is also in your book on page 1617 and 1618. Side studies perform sputum pleural fluid to detect the presence of abnormal malignant cell. Thoracentesis, cervical perforation. So we need to make sure the patient's fully aware, explain the procedure, and get informed consent. Procedure right at bedside, sitting upright, and make sure we go through everything with the patient before it happens so they're not as nervous. So the vital signs we're monitoring: risk for pulmonary edema due to fluid shifting. Place patient on unaffected side after procedure. That's very important. Obtain chest area after procedure. Make sure we didn't collapse the lung. So obtaining learning to abdominal arterial blood. So ABGs really determine which way we're going in our body. So essential two tools for diagnostic monitoring patient respiratory disorders: measures lung ability to exchange oxygen, carbon dioxide. Normal 7.35, 7.45. Good thing you need to know which way is which. So the higher CO2 level, more cytokine. PO2 and the ACO3 is your bicarb, and too high bicarb, low. So we'll go through that. Oxygen carried in bloodstream in two forms: oxygen dissolved in plasma expressed in PaO2, oxygen combined with hemoglobin expressed as SO2. Arterial blood gas ventilation, respiratory components of the acid-base balance, relationship between pH and PaCO2. The CO3 is measured metabolic components of the acid-base balance. The kidneys will respond to alterations in the pH due to respiratory conditions by wasting or retaining ACO3. So here's how we get ABG. Make sure we do the Allen test. Make sure you can have both arteries are working. Check on identifying normal ABG. And here we went through the ABGs. Now we're going to hand out some questions. We're going to go through them as a group, and we'll interpret going through back and forth how ABGs are interpreted. So check on learning. We come back from working on ABGs. Now, patient recently had a thoracentesis procedure and is being assessed by the nurse. Which is the most concerning? So we want to give the students enough time to answer the question. And I'm raise your hands, have a few people ask it. All right, it'd be diminished breath sounds on the affected side. So we need to let the provider know as well. So next, what is the functional unit for gas exchange in the lungs? Yes, it's the alveoli. Alveolar capillary membrane is the functional unit of the actual exchange of air. So summary of the key terms we went over: anatomy, physiology, nursing assessment, diagnostic tests, EEG interpretation. We worked on that as a class. Any questions? And all materials are referenced from the book that practical nurse students use, plus from the Fort Sam Houston, which controls the practical nurse course from the United States Army. Thank you very much. Again, this is Joe Newhouse presenting, and this is the end of the presentation.